So we're going to talk a little bit about redefining geriatric fracture fixation, IlluminOss, and hardware as the new platform. And the way we do this is I'm going to kind of talk a little bit about some of my indications and thought process with regard to when I utilize IlluminOss as a bone augmentation device, and some of the considerations, and just some of the, honestly, I think we're all still learning and exploring some different areas for utilization. And so that's part of the excitement of this, because I think we're all faced with a lot of the same challenges with regard to some of these older patients, some of their challenging fractures and injuries that they present with. And then I think the impact that we can have in terms of getting them up and moving sooner. So this is, I think for disclosure wise for Dr. Barei and I, this is a sponsored lecture by IlluminOss, but meant to be a discussion and an educational for everyone involved. So, the challenges of geriatric fracture fixation, a lot of these folks, regardless of some of the anabolic medications and interventions that, they are on, have poor bone quality. And this can be poor, and people can be osteopenic or osteoporotic. And then some situations, it just can be straight up miserable. And, the impact that has is that it just means that the metallic implants that we use are only as good as the bones that they are positioned within or attached to. And so for plates and screws, lag screws don't compress well like they do in younger bone. The cortical screws lose purchase easily, especially if the implant doesn't sit directly on the bone. Utilizing a non-locking screw to decrease the space between the plate and the bone is challenging. And locking technology can only do so much, right? We have fixed angle constructs, but if it's swimming in poor bone, will that withstand the weight bearing that you want it to? Medullary nails, oftentimes, regardless of the large diameter, can't match the cavernous geriatric canals that they exist within. Um, they may be okay in the diaphysis, but once you start getting to end segment fixation, it can be challenging. And that's when I think people are thinking about dual implant fixation historically and things like that. And the interlocking bolts that we use to prevent rotation and change in position of the nails still just exist within this poor bone. So even if they're fixed angle interlocking bolts, they can only do so much. And so we're really pushing to mobilize these patients earlier, despite these increasing challenges. And so I think for me, bone quality that needs augmentation is a great opportunity for use of IlluminOss. Improved fixation for both locking and non-locking screws when I'm using a plate and screw construct, and I think we'll see some examples of that. And then I think one of the interesting kind of avenues or thoughts is that the IlluminOss, because of its ability to be positioned in and around other implants, especially in the medullary canal, can fill space between the nail and the bone, can support this end segment fixation, especially in distal or proximal segments in the femur. And I've seen a lot of great cases from folks around the country kind of utilizing it in that manner. And then if you can position it correctly, it can really improve the fixation of those interlocking bolts that you place within nails. So this and the fact that it can be placed with pretty minimally invasive techniques means it's soft tissue friendly, can help preserve the biology of the area, and it can be pretty impactful. So, at least in my mind, when I see some of these fractures and encounter some of these challenges, this is what's going through my head: is can I augment my fixation to utilize the standard medullary nails, plates, and screws that I have always used, but improve their ability to function and work. So I'm going to stop here and turn this over to Dr. Bray, because I'm similarly excited to see some of the cases that he has, and then I'll show some, and then we'll kind of regroup and chat and hopefully generate some good discussion.
I think that for me, the distal femur was the initial impetus for me to start using the IlluminOss device, and it was because of the geriatric bone, particularly around the total knees that had periprosthetic fractures, that I found lateral fixed angle isolated plating was lacking. And so, this is where I first kind of got interested in using it and augmenting it. And two plate constructs are great, but if you have a contraindication or there's some other compelling reason to not go onto the medial side, then that minimizes that utility. If there's a medullary nail is great. What if you can't get it through the box for whatever reason? What if you just can't get fixation around your nail? Then that becomes a subsequent frustration. So to me, this was a good device, and it was probably one of the first indications that I had. And then let's just use this as an example. You know, I got a 270-pound fella, 72 years old. He's got bilateral periprosthetic supracondylar distal femurs from a high energy mechanism. He's got diabetes. He's got neuropathy. His implants of his total knees are starting to get a little bit aged. He's got EFib on Eliquis. He's typical. This is your typical kind of guy, and you know he shows up with these kinds of fractures, and so he's got a big physiologic force with a comminuted metaphysis right at his total knee, and both of them are pretty significant. In fact, I think that the left-hand side, the one with the stem tibia component, is beyond fixation when we go and look at his CT scan. But his right side, I think, is even that one's a bit of a challenge. And I thought this was a great indication. He's a big fella. I don't feel like using a medial-sided implant. I don't feel like bumping into all of my metallic nail. And so I chose an IlluminOss device. Now, some guys will use the IlluminOss to help them with the reduction. I tend to use the plate or adjunctive means to go ahead and get everything all teed up so that I can put my IlluminOss device in a pretty reduced standard kind of way. And so then when that's in, then I'm simply using my fixation to go ahead and change things around. So, or to stabilize it with definitive fixation. So when you look at this, you know, you see it's been changed. I've used my implants, I've used bicortical screws, I've got my reduction, and then I just make way for the device, which I can put in retrograde through the box if it's open. But if it's not, then I can go ahead and put it in through the medial side. And there's even times where I've gone ahead and put it in antegrade all the way down for whatever reasons, and then been able to fill the canal and make use of that, and then have fixation available to me to go ahead and finish off my fixation. So much like you would with a medullary nail, you know, short fixations, leave space for the nail, put in the nail, except here now I can go ahead and drill through it, and I can go ahead and stabilize everything and take advantage of the rigidity or the physical structure of the IlluminOss device to go ahead and make my fixation that much more substantial. And through that, then I can allow him to go ahead and heal. You know, some of these folks, for me, you know, really older folks, it helps with weight bearing, as John has alluded to, and is a primary compelling reason to maybe use this device or augment your fixation with something to go ahead and get them to weight bear sooner. And of course, his other side goes ahead and gets a distal femoral replacement, and that's tough for him. You know, he's a 72-year-old guy that, you know, I don't know how long that's going to last, but hopefully this one is going to last a lot longer. So a good example for that. And then for me, the upper extremity has really been something that I've been very interested. I was just telling the guys before, this might be one of my favorite operations now, is the geriatric or the poor bone quality person with a humeral shaft non-union, that I think is a great indication for the IlluminOss device. So here's a fellow, he's not geriatric, but wait till you see his x-ray. You know, he's had a ballistic humeral shaft fracture, put in an X-fix 5 years ago. His X-fix was off after 4 months. He's got a mobile, painful non-union with limb neglect, basically, with the inability to function for 4.5 years now, you know. So he's got a mobile, painful, malaligned humeral shaft non-union with this, you know. And if you look closely, even though he's 47 years old, look at his cortices on both the AP and lateral. It's terrible. And so even though this is a younger person, his bone is effectively rotten. And I think this is a great indication, at least for me, to go ahead and use the IlluminOss to give me some sort of fixation. Because as John alluded to, our medullary implants for this really are poor quality for a non-union situation. So for me, you know, I can reestablish the medullary canal. I can realign him I can use a provisional plate. I can inflate the IlluminOss device or insufflate it or fill it, and then do my definitive fixation. And through that, go ahead and pretty rapidly give the guy a good solid arm for the first time in 5 years. And he can go ahead and use that properly and quickly. There's another one, 60-year-old. Look at this guy, treated non-operatively, 16 months after injury, long-standing end-stage diabetes, renal failure on dialysis. He's mostly blind. He's really disabled with his non-union. It's mobile. He can't use it. He can't even get himself around in his house because he can't see anything. His arm is untrustworthy. I think to me, this is a perfect guy because once you give him a stable arm, he's going to use it right away. This is how he shows up. These were his original x-rays. So he's got a comminuted proximal humeral shaft. This is, I think, a good candidate for non-operative treatment. It just didn't work. And so here he is now. Once again, look at his cortices. Terrible bone. I don't trust any of this. He's going to use it right away. So I don't want to have questionable fixation. Same idea. Recannulate the canal, obtain some sort of a reasonable reduction, provisional hold, ream the canal, fill it up with the IlluminOss device, and then put on some definitive fixation. He was using this immediately and grateful for that. And no doubt that I was confident that he could do that because I've got much better fixation than if I hadn't used something to augment my traditional fixation. Gonna give you another one. 7-year-old lady, low energy humeral shaft fracture treated with functional bracing, converted to a nail about 8 weeks later. Now she presents after 1 year post nailing with painful humeral shaft. And even though she's fixed, she says her fracture still feels mobile. So this is her after her nailing. And look at her canal. Look at the nail, just what John alluded to. Even this is an isthmic or a mid-shaft fracture. The nail's just floating in here. And then after a year, you can see she's just toggling around and spinning on this. She feels unstable. She can tell that her arm is moving around and it's not trustworthy. So for me, this is a great indication, once again, to breed all this. She's already got a nail that can come on out, and I just have to enlarge the canal a small amount and insufflate it. But I want you to look at what the IlluminOss, the space it's occupying. Everything inside of that canal is empty. There's no great fixation that you can get from her own native bone. If you look really closely, you'll even see some of the indications that all this is so deficient that you can basically see the device through her bone, or at least through some of the perforations along that side of her bone. So we've taken care to try to bridge some of the stress areas, especially that lower interlocking bolt deficiency, and fill her canal up. She feels immediately great, and we can just follow her along, let her use her arm. I'm confident that she's stable for the long haul. Here she is, 3 months, feels great. I'm just going to show you one last one, same theme. This was just 10 days ago ish. 63-year-old woman, proximal humeral shaft fracture treated non-operatively. She's got a grossly mobile non-union at 6 months. She's got type 2 diabetes. She's had a previous CVA, and she has the occasional seizure. But more importantly, she has this spontaneous left upper extremity tremor that she'll get, which is unpredictable. And she'll get it throughout the daytime. Her arm is normal when it's not doing this. She has a minor amount of hand weakness, but she'll get this tremor. And so to me, I have to be ready to predict or to give her fixation that can withstand some of this non-purposeful neurologic discharge. So here's her injury x-ray. She gets put into a functional brace. You could argue at this time, maybe that should have been an indication to go ahead and fix her. But she was treated non-operatively. Here she is, 6 months, grossly mobile, no strength. It hurts. And I suspect her bone quality is not great. But if I look at this, her bone quality looks maybe not too bad distally. I'm worried about everything in the proximal segment. It looks empty. And given her neurologic status, I don't want to have questionable fixation, because if she starts having involuntary muscle contractions, it needs to hold on. So once again, through an intralateral approach, we mobilize her non-union site, extensive mobilization of her radial nerve, realign her, reestablish medullary canal, provisional reduction. And for this one, I used a differential IlluminOss. It inflates a little bit bigger proximally, a little bit less distally. And we can go ahead and kind of make sure our filling of the canal is a little bit more aggressive, approximately where the deficiency is. I can go ahead and hold her with the provisional plate, get rid of the clamps so I can put on her regular implant. So this is her immediate post-operative films. Like I said, it still has her stitches in. But to me, this was another really good indication. I think for me, these proximal humerus or these humeral shaft non-unions in this poor quality bone, in addition to the lower extremity stuff, this has really been great for me in my practice, because I think this is a great way to augment the stability that we don't quite have with the lower extremity. We're not augmenting this with a medullary nail, or we can use multiple plates, but really this is a plate dependent situation, and augmenting the canal with the IlluminOss for me has been great. Prior to this, I was putting in medullary fibulas and things like that. A big fit problem, big fill problem, and I've had fibulas that I've hit with screws that have fractured on me, and so this has really been has helped me steer a little bit significantly away from doing the freeze dried or the allograft fibula struts that don't quite fit the medullary canal, that don't quite fit, and you get one that's short, you get one that's skinny, and then you hit it a few times with a 2.5 drill. Next thing you know, you wonder the structural integrity of that thing anymore. And so this, I know I can count on, I can trust, because of the size of it, and I choose that size.
Yeah, you may not remember, but I do remember a case during my fellowship year where we did like a hemicortical tibial shaft into a humerus non-union, and um, it was memorable because of the craftsmanship that it required to get that thing to fit inside the medullary canal. But
Yeah,
then, but it's challenging. But that's kind of where I think of IlluminOss, right? It's all the places where I would have used some sort of allograft strut previously to provide some sort of medullary support. But even when you start contouring those, when you use a hemicortical femur or hemicortical tibia, right? You have a semilunar, you know, geometry that you're trying to wedge within a medullary canal, and then you have to figure out if you can, you pass it up further proximally and then slide it distally, and then you can never, regardless of what you do, you can never get it stem to stern because you're
yeah,
really just because of the logistics of getting it, within the
yeah,
canal, and you don't always, unless you're hitting it en face with a drill and a screw. If you come at it from an angle, you may, you may skive off, or you may take, it may become challenging to actually engage the medullary,
yeah.
cortical allograft that you put in.
100%. And I've burred down fibulas to get them to fit, only to wonder. I think I'm only putting in the medullary canal of the fibula at this point, because I've thinned the damn thing so much. It
Yeah.
was basically useless. So
Putting in little matchsticks.
that's it. Yeah, it's
Yeah.
ridiculous.
All right. So, um, start with a distal femur case again, similar to Dave. I think kind of my first. Well, to be fair, my first foray was in the upper extremity, again with a poor, a poor host in terms of someone who could be reconstructed, and wanting to generate some stability. But the distal femur, I think, is a very obvious one. So, this is a 63-year-old female, fall from standing, has a history of a left total hip, which you see above. Patient already has some arthritic changes in the knee, and 3D surface rendered CT, as well as axial and coronal imaging, showed simple intra-articular involvement, but pretty low. And the cortices, are thin. The medullary canal is large, and so you know utilizing a plate and nail technique, I think, would be most common, or maybe a dual plate construct. I think most people would see it. The situation you have to then think about is, okay, if I'm going to use a metallic or a titanium medullary nail, do I run that all the way up to the hip stem? You have to measure that out, and then utilizing a lateral plate, working around that nail. And if you use a larger nail, which, biomechanically is more stable, there's just less room that you have to work with your lateral plate. And so, some of the new periarticular and periprosthetic plates have staggers. I think the vast majority of them now have staggers, and so it makes it a little bit easier. But I think it still remains a challenge, especially if you want to put a screw kind of within the central portion of the bone and not be very anterior or posterior. So you're utilizing the plate just as Dr. Barei had mentioned. Same kind of thing. You can get an idea of utilizing the plate length. You want a plate that's going to bypass the stem appropriately, and utilizing wires as well as a push-pull device proximally just to get the fracture well aligned. You can see I still have an external fixator in place. I'm using this kind of like a long universal distractor because I have the hip stem proximally. I have a pin that's anterior in the diaphysis of the femur on the left-hand side there, and I have a pin more distal in the tibia, which is helping me to provide some length. Because if I remember correctly, this patient was it was short and it was at an outside hospital for a period of time, and so just getting her out to length um, was challenging. But now that I have my plate in place, my bone reduced, this is the medial column here, which would be ideal for either a second plate or some enhanced stability. And so I really like the awl, especially in these patients with poor bone quality. You can use this through a percutaneous incision, identify the correct starting point just off the articular surface on the medial side here, and I'm positioning this exactly kind of where I want to, and then passing the device, and then inflating it, and then once my IlluminOss is inflated and set, once the monomer is set, then complete fixation distally, and that whole area of metaphyseal combination with that cortical fragment that's pushed off, I feel is now better supported and can proceed with kind of standard fixation techniques. And so the nice part about this is the leg is a little bit larger, and you can just see from my staple lines kind of where my incisions were, and this is her as she goes on to heal. I let her weight bear immediately on this. The reason I put her in is because I just saw her about a week or so ago. I apologize for the kind of wonky rotated film on the far right hand side, but I think the lateral shows that she's healed very nicely, and everything is holding well within the plate. And you see kind of where I ended the IlluminOss and the length of the plate here. So I don't think I needed a longer IlluminOss. It didn't need to necessarily go up to the hip stem, but was able to utilize it for a couple points of cortical purchase in order to spread my fixation. So again, immediate weight bearing, which I think is really important. I have, Dr. Barei showed a implant entry through the notch of a total knee arthroplasty. And one of the questions that always comes up is, where do you insert it? Do you come in through the notch, or do you come in from the medial side? I think both have been done, and I surely have done both. In this instance, I thought, I really wanted to support that medial side, and so instead of introducing anything into the knee whatsoever, I just kind of stayed off to the medial side. So that was my choice in this one. This is a case that I did earlier in the year, and I brought it up because it's one of the areas that I've started to think a little bit more about IlluminOss, and still trying to figure out exactly how it fits into my treatment algorithm. A 73-year-old female, diabetic. She has a history of a GBM that was treated, but she still has some neurologic deficits, so she has a lot of falls. And so she has this bicondylar tibial plateau fracture, which occurred in a local outside hospital. And you can see this is just, I'll show you a little bit of a better view, but she gets placed in a knee immobilizer initially, and you can see kind of what's happening. Although it is bicondylar, a little bit of an extended bicondylar pattern, it has that look of a knee fracture dislocation, right? The lateral femoral condyle depresses a large portion of the lateral plateau. The medial plateau is one big piece, and there's a shear, a medial shear of the distal femur and medial plateau, relative to the shaft and lateral plateau, which is still, I'd say, minimally displaced. She gets put in an external fixator, maybe not necessarily pulled out to length as well as she could have. As you see, the lateral femoral condyle is still within the central and lateral aspect of the plateau, and this is how she gets kind of shipped over to us. By the time she comes over to us, she has a large amount of ecchymosis on the medial side. You can see her soft tissue envelope. It's not crazy, but she definitely has a little bit of a larger leg, and so I have to be cognizant of, if you know that geriatric soft tissue, where a lot of it is based on adipose and becomes degloved very easily. I think that was one of the things that I remember most about her. Some coronal CT scans just showing that depression on the central and lateral side. And so, not something that I'm going to use an intramedullary nail on, but maybe an opportunity to support that medial side as long as I can get it, reasonably well reduced, and support my fixation. So get her into, actually just utilize the same X-fix that she had, but really pull her out to length. You can see some of those fracture lines as they extend distally, and looking at her CT scan, extended definitely into the proximal area or proximal portion of the diaphysis. So first I need to address the articular component, and this is a little bit challenging because her exit point on the lateral plateau, you can somewhat see it on the left-hand fluoroscopic image, actually is almost central, and so utilized a knife, really. I would love to say that I used a saw to create an osteotomy, but I just accessed it through with a sharp 15 blade, was able to cut right down onto her lateral plateau to access that, and then start reconstructing the joint. And it was challenging. It was in a bunch of pieces, but really, once I thought I had a good flat joint, I had a submeniscal arthrotomy, as well as some visualization through my fracture site there, to get her joint lined up to, I thought, the best that I could do. It was still challenging, for sure. And then use a long plate to restore her medial and lateral condyles and the height. And so once I had that in place, fixed it with a couple screws, one anterior and one posterior. I was happy with my joint line. I was happy with the relative alignment of my proximal tibia, and then use the IlluminOss to provide myself some medial support. And so again, you see the awl here just off the articular surface. I can sight it both on the AP and lateral fluoroscopic image, and then pass it. I have my plates holding my position, and then use a long IlluminOss to bypass, where that fracture completed, and a little bit farther than where the plate was. I had the push-pull device distally, outside of where my IlluminOss was going to be positioned. But you see the fill that I get in that metaphysis, which is what I really wanted, right? That area of instability that otherwise would have been supported with a plate is now entirely filled. And then complete my fixation. And this was nice because I was just able to use, a percutaneous jig, and a single plate here. And this is what I finished off with. And then her initial, she's radiographs like 6 weeks or so. And then I just saw her recently I think she's about 4 or 5 months right now. And she has nice healing posteriorly. The medial side looks to continue to heal well. The distal portion of that cortical fragment is consolidated and healed. And I still kept her off of it for a period of time just because of the amount of that articular surface, which was involved. But now she's I think at 10 or 12 weeks, pretty standard. I let her start weight bearing, and so she's been walking on this for over a month now, and pretty happy. So yeah, a tough articular reduction for sure in an older patient. And so I think I get a reasonable grade on that, but I think it was helpful in terms of supporting my fixation because I don't know that even with that metaphyseal uh, area that hadn't completely healed, if I'd be confident to let her to weight bear immediately or weight bear, when I did otherwise. This is a patient, somewhat similar to something that Dave showed, 83-year-old ground level fall, right arm pain, deformity, and this is pretty standard for me. This fracture extends up a little bit more proximal. You see, it extends up into the tuberosities, and the fracture lines extend all the way up from that kind of proximal diaphyseal position up towards the lesser and the biceps groove there. So I'm going to plate this, regardless. Not something that I'm gonna nail with a standard intramedullary nail. I know Dave showed it a couple of times, but I didn't have to restore the medullary canal here. But knowing that I'm going to access this um, from the location of the fracture, I really like the technique of kind of retrograde start point, and so using the guide wire and then finding my start point or my ideal start point from the medullary canal, and then exiting that proximally, and I'm checking this on both views, and then creating an entry path as you see on the right-hand fluoroscopic image. And then standard construct with regard to plate fixation, I'm going to plate from, across the fracture. I use an adjunctive mini fragment plate. It's somewhat, anti-torsion, but also supplemental fixation. But the nice part here is that, again, using the IlluminOss into the head, I can engage fixation from the locking screws proximally. I don't have to worry about going all the way to the subchondral bone because I don't necessarily need to fix the proximal humerus. I just need to make sure that I have control of the tuberosities, which I do with some additional sutures, and then use a standard plate that goes down to the distal diaphysis. And so this is what that looks like on the AP and lateral views. This is the more similar to the non-union case that Dr. Barei showed. 70-year-old female, right upper extremity pain and instability. She had fixation a year ago. Someone had gotten after her bone with a bunch of mini fragment screws and one of these plates that kind of spirals around the humerus to end more anteriorly. You see the plate is broken, and the mini fragment plate and screws have loosened. So she has gross motion in this arm. She's pretty unhappy, and just another example of kind of again utilizing the medullary canal from the fracture side of the non-union zone to find my start point, and then with the fracture reduced and clamped, then passing my wire, passing my reamer, going all the way down to the fossa at the distal portion of the humerus, utilizing the IlluminOss, and then at least for me, you'll see a lot of kind of dual uh, implant constructs here. I think Dr. Bray showed that as well. I think as we all recognize the torsional forces that are present on the humerus and allowing these patients to move right away, I think this is helpful, but really nice to be able to engage the IlluminOss device kind of all the way down. And so this is what it looks like, final construct. Uh, and then I just saw her. This goes to the question of whether these heal. You can go from my initial implant images here to the final radiographs on the far right-hand side here, which was, I think, about a month or so ago. I just saw her, very nice lady, and so that's healed. I would consider that healed. I think that fracture is consolidated, and one of the things that you'll notice when you utilize this is that the screws don't toggle, they don't loosen, they don't windshield wiper, and once you engage that, I think it really helps the stability, and the fractures benefit from that stability. Um, One last one, and this is an area that I'll credit Mark Lee because I've seen a couple of his cases and utilizing this implant around nails. I think is really interesting. And so we've all seen this fracture, right? These are low functioning individuals with just cavernous bone, these distal tibia fractures, spoke about the nail diameter and what that does. And, you could put a 13 millimeter nail in this thing and it still will look like a pencil within that distal metaphysis. And even in the diaphysis proximally, you wouldn't even have to ream. And this bone quality is really poor, right? And so the interlocking bolts are not going to be holding well. 3D reconstructions, you can see the calcifications of the artery, and place our guide wire, have this lined up. And this is, I think, is a 12 millimeter. I think we use a 12 millimeter nail here. It's a little bit of a larger nail. Use a cortical replacing uh, wire just to make sure that we guide the implant into the correct position. We have our alignment, and with that 12 millimeter nail in, you can still see the mismatch between the nail and the diaphysis as well as the distal metaphysis. And so uh, you can utilize the medial malleolus as a start point. For the IlluminOss, you can still I'm getting the 7 millimeter reamer up into that medullary canal, and then inflating the IlluminOss just adjacent to the medullary nail on the medial side. And with a little bit of pre-planning, you can then make sure that IlluminOss is positioned such that your interlocking bolts actually engage that as well. And so now I have an intramedullary nail, I have the IlluminOss up the medial side, and interlocking bolts, which at least the proximal one is engaging. The proximal medial to lateral one is engaging completely that IlluminOss device. And so can let her. I just let her weight bear immediately on this pretty confidently because I am happy with my fixation here. This was just not that long ago, so I apologize for not having follow-up. But I do have two other ones where I've done this and been very happy with the overall effect on their ability to weight bear on these right off the bat. So, so for me, the advantage of the IlluminOss improves fixation of screws and bolts, right? We're utilizing standard fixation techniques. We're just augmenting it. You can expand and fill the length and width of the medullary canal if needed. We didn't get into it too much, but the nonlinear corridors, still do a reasonable amount of pelvic and acetabular work. And so for posterior column, superior ramus, areas where a nail, or a long screw can't be utilized, I think this is really helpful. You avoid the need to avoid. We talked about that earlier in terms of placing implants around other implants. Here the intention is to engage the IlluminOss implants, and it's minimally invasive, which I think is really nice. I think some of the exciting areas are arthroplasty, geriatric pelvic ring, which we all see more and more. The distal humerus, which I love. I think it's an easy access point through the posterior aspect of the radial column for distal humerus. And I have a couple cases that I didn't include here, which show that. The distal tibia and, again, proximal femur, which I have not gotten kind of into in terms of usage, but I think there's some real interesting discussions about where we can, utilize this implant there. And then just to finish off, the question that always comes up is what about removal? And I include this QR code. There's a nice YouTube video that was done kind of on some of the techniques for removal. There is no way to deflate the monomer. It's drillable, so threaded wires and pins are very effective at removal. And I will say some of us spent a little bit of time about a week or so ago putting in almost a dozen of these things and taking them out from various different places and in cadaveric specimens. And I think there's going to be some more information and some helpful guides in terms of techniques to remove them. But I think we're all really happy with how that lab went and the removal of these from challenging places, including superior ramus, posterior column, distal femur, medial distal tibia, through the medial malleolus. So more to come on that. So stay tuned. And with that, I'll turn it back to Craig. Thank you very much. Appreciate it all.